of platelets, the coagulation system, and so forth. And then he moved his scientific career into trying to understand the atherosclerotic plaque formation and development, as well as acute coronary syndromes. And he's the first one who actually used coherent tomography or OCT in cardiology. He did the first human case. And actually he moved in this field very rapidly in trying to understand the disease from the OCT point of view. And more recently, he developed an international registry, which has produced a significant number of papers, very interesting papers about the pathogenesis of the atherothrombotic process. I have to say a few things about IK. He was born in Seoul, in Korea. He moved to the Mass General Hospital in 1987, and then he did his residency in medicine and fellowship actually was in Louvain. This very interesting movement from Seoul to Louvain to the Mass General, where he finished his fellowship program in cardiology. And then he moved very rapidly into the academic ladder, and he currently holds the title of the academic title of Alan and Jill Gray Professor of Medicine at Harvard Medical School, and Michael and Catherine Park Endowed Chair in Cardiology at the Mass General. Two titles, which is very, very difficult to have in any academic institution in the world, and certainly in the Harvard system. I have to say that his accomplishments are numerous. First of all, let's say he's in the editorial board of most of the journals that we read, and I don't have to go over. He had numerous awards in his country, in Louvain, and then in the United States. He has been a member of the nomination committee for the Nobel Prize in Physiology and Medicine for a number of years, even now in 2021. About his scientific career, I can say that the number of papers that he published in peer-reviewed journals is fantastic. He has more than 300 papers. And I just have to say that he's one of these few individuals that you always keep in mind, not only because of his scientific career, but I have to say he's a fantastic person, high ethical standards. I know him and his family very well. And again, he's one of these unique individuals that you always keep in mind when you talk about role models. Well, anyway, it's a pleasure to have you here today, IK, and ready to listen to you.
Thank you very much, Dr. Fuster. I just lost my word. I don't know what to say after this kind of introduction. If I can add just one thing, I was hired by Dr. Fuster, and I vividly remember my job interview with Dr. Fuster. I believe we had 20 minutes for our interview, and it didn't take more than 2 minutes. Dr. Fuster said only 3 things. At that time, Dr. Jang, I know you, I know what you are doing. Very nice meeting you. That was it. That was very typical Dr. Fuster style. Okay, so today I'm going to share my experience over the past 20 years. Dr. Fuster, is the screen okay?
Yes, excellent.
Okay. Over the past 20 years, as Dr. Fuster mentioned, we started this from bench all the way to bedside. So this is my disclosure. And I'm gonna divide my talk into 3 parts. First, I'm gonna briefly summarize development of OCT in cardiology and introduce some early studies. And main focus of my talk today will be pathobiology of acute coronary syndrome, particularly plaque erosion, the topic that our group has been interested in over the past 10 years. And then I would like to share very exciting new data, layered plaque or healed plaque. And also I'm gonna introduce new classification of calcified plaque in living patients. So this is the history of OCT. OCT was developed by Jim Fujimoto at MIT in 1992. And 6 years later, two scientists, Brett Boomer, Gary Tierney, came over from MIT to MGH. And three of us formed an MGH OCT cardiac OCT group. And after 2 years of bench work, it took a long time to develop or to make a safe rotary junction. And following small animal and large animal studies, in 2000, we performed first-in-man study. And until then, it was pure research tool. It was really cumbersome. We had to take multiple steps to acquire one single image. And after single image, we had to adjust all the parameters, which took easily 10 minutes. And 2006, second generation OCT, frequency domain or Fourier domain OCT was introduced. That was a game changer. And 2010, US FDA approved this new technology. That's when we started MGH OCT registry. These are old pictures, 20 years ago, Gary Tierney, Brett Boomer, and this is when we were performing a first-in-man study. It was done in Korea. We enrolled 18 patients in 3 days. We started 5 a.m. and finished 8 p.m. time. This is a prototype OCT that Gary Tierney and Brett Boomer built at Wellman Laboratory of Photomedicine. Very bulky, heavy. And this is the catheter that I used in the first living patient. At that time, with the fund from DOD, we actually purchased commercially available IVUS catheter, and we pull out the core and replace the core with an optical fiber. And this is the rotary junction, which provides safety profile. And compared to this heavy, bulky device, and these are the modern portable and integrated system. So as an interventional cardiologist or clinician, it was my role to set the direction of this new technology. And being interventionalist, obviously I was interested in optimizing PCI using this high resolution imaging technology. But personally, I was more interested in studying in vivo vascular biology using this tool. I will show you a few initial studies. This is one of the, probably the first demonstration of OCT following stent placement compared to IVUS. Intravascular ultrasound with low resolution, you can see more or less the stent struts very bright, and you may suspect a little protrusion or prolapse of tissue. That's pretty much it. Compared to IVUS OCT, you see these black dots are stent struts, and you see prolapse or protrusion. Of note, this dark tissue, this is fibrous tissue. This tissue with low intensity, these are lipid parts. So if you look at the vascular response to stent in the area with primarily fibrous tissue, there is no prolapse, no protrusion. Compared to fibrous tissue, when the underlying plaque has lipid, then you see this kind of prolapse protrusion. When the tissue that covers lipid is thin, this thing happens. The fibrous caps get severed. So this is the first study comparing OCT and IVUS after stent placement. No surprise, OCT was able to demonstrate higher prevalence of dissection, tissue prolapse, and incomplete apposition compared to IVUS, and no-brainer. And since the introduction of OCT 2010, number of studies have been performed to show that OCT is superior to IVUS in terms of optimization of PCI. Unfortunately, pretty much all the studies, including Illumium 1, 2, 3, and Opinion study and others, really failed to demonstrate OCT is better than IVUS. At best, it is equivalent. And just few studies showed some additional benefit of OCT in terms of PCI optimization. And this is one of the few. And small minimal stent area, you can easily get this information from IVUS. However, this irregular protrusion, which is shown in the right lower bottom here, you can only identify with OCT. It is not just random morphologic changes or vascular response. This represents deep vascular injury. Oftentimes media is destroyed. Then you see irregular protrusion. That has correlation with poor outcome. So as I mentioned earlier, personally, I was more interested in vivo vascular biology, as Dr. Fuster mentioned. When you have a new diagnostic modality, especially imaging modality, you need to validate this. So when we got this, obviously first domain, time domain OCT, we had to find out whether this is something that can reflect histology. So we got 357 samples, 50 samples. We first read histology and then followed by OCT interpretation. So we try to understand, for example, histology, fibrous tissue, how fibrous tissue looks like on OCT. And subsequent 307 samples, we read OCT blinded to histology. And then after interpretation, we compared with histology as the gold standard. So this data is from the second set, 307. So all OCT were read without any knowledge of histology. Any diagnostic modality in the clinical setting, which has sensitivity specificity above 80, 85%, I believe is clinically viable. And as you see here, sensitivity specificity for fibrous, calcific, and lipid, they were all way above 0.85. So this is probably the first demonstration of OCT for coronary arteries. So this is cross-section. This is OCT catheter. This is guide wire. And you can see this three-layer structure: intima, media, adventitia, internal, external lamina. You can zoom it twice, 4 times, or even more. As I mentioned earlier, this tissue, dense with high reflection, is fibrous, whereas this tissue, low reflection, low intensity, is lipid. Compared to OCT, IVUS clearly has 3 advantages. One is with a deeper tissue penetration, you can measure plaque burden, and you can also study remodeling process. And in the clinical setting, you can image without contrast. This is the first demonstration of plaque rupture, as far as I know. I vividly remember this case. This was a young man at the time, 57, and now much older, obviously. I was on call that weekend. I got a call from one of the islands, southern part of Massachusetts. A young man who had had bypass surgery previously came in with large infraposterior MI, and weather was bad. So I told them to lyse them. And then obviously we were waiting in the cath lab standby. And because of weather, he flew to Logan Airport, and with the ambulance came to our cath lab around 9:30. And on arrival, he was pain-free. So we continued heparin and aspirin. One day I brought him an image. So this is again OCT catheter, guide wire, circumferential lipid, all low density. And here you see mural thrombus, and this is rupture of thin fibrous cap. Showed different plaque characteristics depending on clinical presentation. This STEMI, ACS, and stable angina. The prevalence of lipid-rich plaque was 90, 75, 58, and fibrous cap thickness 47, 54, 102. If you use the cutoff proposed by Reno Vermani, 65, or proposed by Ionazzo, 80, you can nicely separate this acute coronary syndrome from stable angina. TICFA, we defined lipid-rich plaque with fibrous cap thickness less than 65 microns. And prevalence of TICFA was 72, 50, and 20. And the depth of our understanding at the time, 15 years ago, this was it. TICFA was more frequent. At least I didn't pay attention at that time, 15 years ago, what the rest 28 and 50% really meant. And now, retrospect, we understand 28% of the people with STEMI, underlying mechanism was not rupture, was not due to TICFA. 50% of people with the ACS underlying mechanism was not rupture. Now we know majority of those were caused by plaque erosion. The main theme of our group over the past 15 years or more was atherosclerosis. It's panvascular process, panvascular inflammation. ACS is panvascular inflammation with local manifestation. So in this study, we look at plaque phenotype in non-culprit region, and we compare the plaque phenotype between patients presented with ACS and non-ACS, so stable angina. So compared to stable angina, non-culprit plaque of the patients presented with ACS had greater lipid burden, thinner fibrous cap, much higher prevalence of lipid-rich plaque, much higher prevalence of TICFA. So again, ACS is panvascular inflammation. And Rocco Vergallo from Italy studied this further, and he used a 3-vessel imaging data set and looked at what really means when you see a plaque rupture in non-culprit region. So obviously it's a silent rupture. The prevalence was roughly 20%. When you see a previous silent plaque rupture in non-culprit region, that means patient is at high risk. When we follow those patients up to 1 year, the event rate, major adverse cardiac event, was more than double. Is a predictor for poor outcome. So ACS is panvascular. Yoshi Minami studied, what can predict the vascular response to statin, favorable or unfavorable. Acute coronary syndrome is a panvascular inflammation, so it does respond well to anti-inflammatory agent statin. Whereas CKD, they have unfavorable response to statin compared to others. So this is the main topic, really, of my talk today. This is something we've been interested over the past decade. So whenever we start a new project, after all, our study is all phenotype imaging study. So we do a thorough literature search and from histology, pathology. And erosion, we studied all available published papers from pathology literature and found out plaque erosion is responsible for 25 to 40% of people with sudden cardiac death. So this is not rare. This is not trivial event. This is a serious problem. Whether we can identify or differentiate plaque erosion from plaque rupture, really no-brainer. These are the examples of plaque rupture, again, catheter, true lumen. This is an emptied cavity which used to be filled by necrotic core, now severed, fibrous cap. Compared to plaque rupture, erosion has 3 distinct characteristics. Vascular integrity is better preserved. Lumen is typically much larger compared to this rupture. And this granular structure, this is platelet-rich thrombus. So you don't need much experience. Anybody, beginner, can easily differentiate rupture from erosion. Calcified plaque, which is relatively rare, and typically in the elderly population, has substantive superficial calcium. And this is what Dr. Bermani described, nodular protrusion here, calcified nodule. So way back, maybe close to 10 years ago, we proposed this algorithm to make an OCT diagnosis of plaque erosion. So relatively simple. So first you look at the fibrous cap, whether it's disrupted or not. If it is disrupted, then you get the underlying plaque characteristics. Lipid, that's rupture. Underlying plaque shows substantive superficial calcium with these features, calcified nodule. Fibrous cap is intact with these features, plaque erosion. and some other rare causes. So we studied a little over 100 patients with ACS. ACS is a heterogeneous group, STEMI, non-STEMI, and unstable angina. And we look at the prevalence of erosion, obviously, it was 38%. And you remember the pathology studies showed 25 to 40% prevalence. So obviously we read this OCT blinded to anything. And when I saw this, I almost developed goosebumps. And for the first time now, we can make a diagnosis of plaque erosion in living patients. So next study was homogeneous population, STEMI, in collaboration with Dr. Higuma. We look at the culprit plaque characteristics in patients with STEMI homogeneous. It was lower, 26.8%, lower than those that we saw in ACS patients. And we look at other features of the culprit lesion. The red bar represents plaque rupture, blue bar represents plaque erosion. Compared to plaque rupture, erosion had much lower degree of plaque vulnerability, lower prevalence of lipid, much lower prevalence of TICFA, macrophage, microvessels, cholesterol crystal. Prevalence was much lower in patients with plaque erosion than in those with plaque rupture. So again, plaque erosion has much lower degree of inflammation compared to plaque rupture, but not zero. And in collaboration with the Professor Stefanidis in Greece, we got a number of cases. They're practiced at least during the weekend when patient comes in with STEMI, they lyse them and send them to the university hospital. Successful reperfusion, they wait until Monday and then do cath at the time they did OCT. So Taishion was a fellow at that time, analyzed 10 millimeter culprit lesion. And this is what he found out. 2 points to make. One is this vertical bar, red bar represent red thrombus, white bar represent white thrombus. One, after rupture, you have much greater residual thrombus burden compared to those with plaque erosion, number one. Number two, the predominant component of thrombus, at least residual, is platelet in plaque erosion, rupture, fibrin, erythrocyte. So all consistent. On the basis of these studies and a few others, we decided to launch the erosion study. We hypothesized the patients with plaque erosion might be stabilized by effective antithrombotic therapy without stent implantation, thereby avoiding both early late stent-related complications. We enrolled close to 500 patients, and a little over 400 we had evaluable cases, and then 103 had plaque erosion, and about 1/3 with a tight underlying stenosis. We really couldn't treat them without stent, so they were excluded. And 60 patients was a target number enrolled at index, and 55 1-month follow-up. The primary endpoint was more than 50% reduction of thrombus volume. So this is the result. Again, even though I designed the study for ACS, 95% of patients had STEMI. So this was a STEMI study. The prevalence of plaque erosion was 25%. And you remember that Dr. Higuma's study, prevalence of plaque erosion, STEMI study was 26.8%. So we use same algorithm that we developed 10 years ago. So if the result of two totally different data set produce this level of data, that I interpret the algorithm that we developed is reliable and reproducible. As I mentioned, primary endpoint was reduction of thrombus volume. The median thrombus volume decreased from 3.7 to 0.2, and flow area obviously increased. These are individual data. So this bottom patients, we zoomed up. As I mentioned, primary endpoint was more than 50% reduction in thrombus volume. So these red dots are the cases that met primary endpoint, 85%. 40% of total population had no residual thrombus at 1 month. Thrombus was completely gone. I will show you some examples. This was 65-year-old patient with anti-MI. After aspiration thrombectomy, you see this kind of platelet-rich thrombus. We treated him with the DAPT and GPI. 1 month later, you get this, without stent, obviously. The minimal flow area increased from 2.4 to 4.0, and he did well, obviously. So this was aggressive protocol. We repeated OCT after 1 year. And obviously we followed the patients clinically and repeated OCT. None of them developed ACS, and there was further decrease in thrombus volume between 1 month and 1 year. So conclusion from this, the erosion study was plaque erosion was the underlying pathology is in 1/4 of patients with STEMI, basically. And antithrombotic therapy without stent effectively reduced thrombus volume and increased flow area without recurrent ischemic event at 1 month. And this initial benefit was maintained up to 1 year. Again, we wanted to look at panvascular phenotype. So we look at non-culprit plaque characteristics in patients with plaque erosion and plaque rupture. So compared to plaque rupture, erosion patients had in non-culprit region much lower level of vulnerability. No rupture was found when the culprit lesion had erosion rather than rupture. Lower level of macrophage, microvessels, cholesterol crystal, and spotted calcium. Again, compared to plaque rupture, plaque erosion has much lower panvascular vulnerability. And that's when we started collaboration with the Peter Libby, and Peter Libby, our sister institution from Brigham. Peter has been working on plaque erosion also over a decade, but we've been working independently, although I can get his lab in 10 minutes. And he proposed this 2-hit hypothesis. First hit was disturb flow, upregulate toll-like receptor 2, which damage endothelium leading to endothelial denudation. Second hit was a consequence with the exposure of proteoglycans or hyaluronan. It activates both platelet and fibrin, resulting in formation of NETs, neutrophil extracellular trap. And he vaguely mentioned this disturbed flow. So in collaboration with the University of Melbourne, we did number of projects. First was computational flow dynamics. So this is one of the many, many examples. So flow from right to the left. So this is endothelial shear stress gradient, oscillatory shear index, and thrombus. The thrombus starts in the area of highest endothelial shear stress, and thrombus propagated along with the flow and stop when it meets higher oscillatory shear index. So conclusion from this analysis was 2 factors are important in plaque erosion. Number 1 is endothelial shear stress, and number 2 is plaque geometry. And we extended this study on something not very familiar to most cardiologists is endothelial shear stress gradient. And very interesting finding, which is impressed, as in multivariable analysis, only endothelial shear stress gradient was independently associated with plaque rupture and erosion, not endothelial shear stress itself. And ESSG is significantly higher at rupture site than erosion. So conclusion from this study was ESSG gradient rather than ESS may play a critical role in acute event, identify lesions at risk for future event and discriminate between rupture and erosion. And this really helped me to better understand, because when we thought ESS, endothelial shear stress, was the only factor, I really struggled how to understand this. As I mentioned, ESS and plaque geometry. To increase ESS, plaque geometry should change significantly. Other than intraplaque hemorrhage, I really couldn't understand. Maybe some occasion spasm, but ESSG now explains how this change in subtle ESSG can damage endothelium, leading to plaque erosion. And our ultimate goal was to identify plaque erosion without invasive technology. So we wanted to study clinical and simple laboratory predictors of plaque erosion. And Erika Yamamoto found 5: young, anti-MI, no diabetes, normal renal function, and high hemoglobin. This is not random. Younger patient, no diabetes, normal renal function, low level of inflammation, anti-ischemia, LAD. So LAD compared to circ and right, what's the difference? Among many, LAD is the vessel with multiple side branches, multiple septal and multiple diagonals. So whenever you meet, the flow meets bifurcation, flow perturbation starts. High hemoglobin, high viscosity, high endothelial shear stress and gradient. So these are not random. This explains when a patient with ACS has all these 5 features, the probability of plaque erosion goes up to 73%. So 3 out of 4. So unlike plaque rupture, plaque erosion is a complex process. So as I mentioned, fluid dynamics, high viscosity, LAD bifurcation is important. Systemic factors, hypercoagulability, and spasm may contribute. And then certainly endothelial factors. Smoking, we all know. Oxysterol. So there is some data that Zetia, by blocking oxysterol, may have beneficial effect on endothelium, and obviously NETs. So what I propose for future, not now, paradigm is when you see a patient with acute coronary syndrome, you can easily differentiate STEMI and non-STEMI. STEMI, you bring them to the cath lab. Non-STEMI, you use these predictors. And if patient has high likelihood of plaque erosion, you may want to do something like CT angio. You want to make sure that residual lumen is at least decent. And then potentially you want to use point of care device for biomarkers specific for plaque erosion. Those patients, you don't send them to the cath lab. Conservative management. If likelihood of plaque erosion is low or clear plaque rupture, you bring them to the cath lab. And you do aspiration thrombectomy and you do OCT. If it is indeed erosion, then you can treat them conservatively. If not, you stent them. So that's the future potential paradigm that we have been thinking about. So I would like to share some very exciting data with you, very recent data. So we studied prevalence, characteristics, and clinical significance of healed culprit plaque in patients with ACS. This was the work of Francesco Fracassi. So whether you can make a diagnosis of, or you can detect layered plaque with OCT. This was a drawing of Francesco. You see here multiple layers. This is after rupture. And you see distinct layers. This is in case of plaque erosion. In other words, OCT can visualize these different layers with different optical density, which was validated by Shimokado with the histology gold standard. The prevalence of layered plaque in ACS was 28.7%. And this layered plaque is associated with the features of vulnerability and plaque burden. Clinically, those people with layered plaque at the culprit lesion has higher prevalence of hyperlipidemia, diabetes, and previous MI, so clinically higher risk. And geographically, complex lesion, greater plaque burden. OCT, more frequent plaque rupture, TICVA, and macrophagic infiltration. So both all clinical and geographic OCT, higher level of vascular vulnerability and more advanced atherosclerosis. How about stable angina? We did not separate this study into two papers because the body of data was so massive. So when I submitted this to Jang, I explained to you, to the editors, that we did not attempt to have two papers. The data was so huge. So stable angina prevalence was almost double. It was 28% in ACS and 54% in stable angina. Again, same thing, stable angina. The layered plaque at the culprit region was associated with high level of plaque vulnerability. This was shown also by Rocco Vergallo in JAMA cardiology. So to make long story short, the healed plaque presence at the culprit lesion indicate different atherosclerotic background depending on clinical presentation, almost opposite. In ACS, presence of greater local vulnerability and systemic inflammation, culminating disruption of a healed plaque to an acute coronary event. Stable angina, a healed plaque is likely the sign that plaque had undergone repetitive silent disruptions that have finally reached ischemic threshold, causing supply-demand imbalance. So in other words, stable angina patients with healed plaque, they have probably robust endogenous antithrombotic defensive mechanism, whereas ACS patient had relatively weaker defensive mechanism. That's why at the time of first plaque disruption, they form an occlusive thrombus, present with acute coronary syndrome. And then finally, we had to wait long for the study of calcified plaque because the prevalence is so low. It was done finally by Dr. Sugiyama. So Renu Vermani and Erling Falk, they published calcified nodule was responsible in 3 to 8% of patients with sudden cardiac death, calcified nodule, and they nicely demonstrated. Because the prevalence was so low, we had to wait long until we had enough numbers. Sorry. And the definition of calcified plaque in our study was presence of superficial substantive calcification at the culprit site without evidence of ruptured lipid plaque. I will come back to this. And we found 3 distinct types of calcified plaque. One is eruptive calcified nodule. This is what Renu and Erling proposed, calcified nodule. And we found this totally different calcified type, superficial calcific plate, we decided to call. Looks almost like plaque erosion. And then in a small percentage of patients at the culprit lesion, we saw calcified protrusion. Prevalence, eruptive calcified nodule, what the pathologist had described in the past, 26%. Superficial calcific plate was 2/3, and calcified protrusion was only 6.7%. So the conclusion from this calcified plaque project was prevalence of calcified plaque was higher, 12.4, not 3 to 8%. Interesting finding is eruptive calcified nodules are most frequently located in mid-RCA and frequently associated with red thrombus. So mid-RCA is the part of the vessel with the greatest torsion during contraction and relaxation. So calcified sheet or the nodules of calcium with a torsion, they get disrupted and they protrude into the lumen and cause local flow turbulence leading to red thrombus. Whereas superficial calcific plate is most commonly found in LAD. And white thrombus is the predominant type. Again, a feature similar to that of plaque erosion. which has also narrow lumen, high shear. So this is a new algorithm that we propose. Patient with acute coronary syndrome, some rare causes, and you look at the culprit plaque. When you see lipid plaque with fibrous cap rupture, then that's a plaque rupture, simple. If not, you look at whether there is substantive calcium. If not, that's plaque erosion. If yes, then that's a calcified plaque. And you look at whether there's eruption of calcified nodules. If yes, that's an eruptive calcified nodule. If not, you look at whether there's protrusion. Yes, then that's a calcified protrusion. If not, that's a superficial calcific plate. So this is new algorithm that we propose in this study. So I will summarize what I have shared with you. So in vivo characterization of coronary plaque phenotype has become possible with the introduction of OCT. Again, ACS is a pan-vascular inflammatory process with local manifestation. And ACS is a predictor for favorable vascular response to statin therapy. And chronic kidney disease is a predictor for poor vascular response to statin therapy. Plaque erosion is responsible for 25 to 38% of patients with acute coronary syndrome. Conservative management with antiplatelet therapy may be an option for patients with ACS caused by plaque erosion. Local flow perturbation, especially ESS gradient and plaque geometry, may play an important role in plaque erosion. And predictors for plaque erosion have been identified. Healed plaque at the culprit lesion in ACS indicates pan-vascular inflammation vulnerability. Healed plaque in stable angina patient is likely the sign of repetitive silent disruptions that finally reach the ischemic threshold. Now, 3 distinct subtypes of calcified plaque have been identified. And this is it. And obviously, this work was not done by me. It was done by fellows. And more than scientific contribution, what I feel most proud of is I trained over 30, maybe 40 fellows from all around the world. And many of them have become leaders in their own country. And special thanks to Bobby Ye, who helped me to develop database, and Aaron Naguri is a brain from MIT and MIT Harvard MD PhD, and Iris has been working with me for over a decade. These are my collaborators, and some of you may not know, and Dr. Fuster has been an advisor from the beginning, 10 years ago when we established MGH OCT registry, along with Professor Jin Fujimoto at MIT. Last several years, we've been working very closely with Peter Levy, who taught me so much so that I can set the future direction of our work. And last 2 years, year and a half, 2 years, we've been working closely with Professor Ye Christ. It's a Korean Advanced Institute of Science and Technology. And then we work very closely with Professor Krea and Biasuchi from Catholic University, my alma mater, University of Louvain, and flow dynamics and ACS predictor studies. A few years ago, Dr. Yones organized OCT symposium in Tokyo, and our group was introduced as an MGH gang in Japan. And I guess I was the godfather at that time. And with that, I will wrap up my talk. Thank you very much.
Well, thank you very much, IK. A beautiful presentation. You certainly have been one of the main contributors to the understanding of the atherosclerotic process. Now, let me ask you a question. This week in JAC, we have a paper which is about stable coronary artery disease. And the question is how to go after, what to do. And here comes my question. I may not know if my patient has coronary artery disease or not. Probably yes, And the approach is to do a CT angiogram, all right? The
Yes.
CT angiogram, which is going to become very, very, as you know, the opening door to this disease, shows some coronary artery disease. And here's my question to you. You say, well, if there's coronary artery disease, let's do OCT. And the question with OCT is if you see multiple layers, means this patient is in trouble. But my question is, how many patients that we can see with having coronary disease with CT may have erosions? And how many of these patients may have vulnerable plaques? Because that's the issue. The issue is trying to predict what is going to happen to these patients. And this is my specific question. How many vulnerable plaques or how many erosive plaques do you see in the stable patients, or whether it's possible to address the erosion?
Wow, this is a really loaded question. I didn't expect any easy questions from you. Let me just first answer to your CT question. In my practice, I use more and more CT, but what I see is, CT provides only anatomic information unless you use CT with FFR. In the cath lab, we are moving away from anatomic decision-making to physiologic decision-making. And outside the cath lab, we are going opposite direction, right? So instead of using physiology stress tests, which I always thought the best test in cardiology practice, we are moving away from exercise tests towards anatomy. In almost over 90% of patients over age 50, 60, if you do CT, how often do you see clean coronary arteries? Very rare, which will lead to catheterization, oftentimes unnecessary. So, my resistance to CT, that's my question, number one answer. Number two, vulnerable plaque. And I wrote the editorial in European Heart Journal last year. The vulnerable plaque, per definition, has to be a plaque that is prone to rupture, causing major clinical problem in the near future, not in 3 years, not in 5 years. So it's got to be really dangerous plaque. And we and others have shown when you treat patients with high intensity statin, there are 3 vascular responses or plaque response. About 70% plaque does not grow. Actually, plaque shrinks, regression. About 10% plaque grows, but linear, slow. About 20% plaque will grow abruptly, stepwise rapid progression. So when you saw a plaque that you think is vulnerable, if you treat them, and you treat them that we can stabilize with statin and others, 70, maybe 80% of people may undergo unnecessary catheterization. We also have ad hoc analysis from our data. We have identified TICFA, patients with TICFA, and followed up to 4 years. 1% of those people with documented TICFA had MI, 1%. So if you start treating patients only because you think patient has vulnerable plaque, 99 out of 100 patients will have unnecessary stenting or whatever, local treatment. So I am a little bit against, the local detection of vulnerable plaque and treat them locally or segmentally. I know the recent study, Prospect Observe and Prospect 2, but we have to interpret the result with some caution.
Yeah, thank you very much. I think my question is actually driven towards that end, and that is there are many vulnerable plaques.
Yes.
And the number of events is probably very minimal. And my question is, there are many plaques with erosion, I suspect.
Yes.
And I suspect, and the events are also minimal. So you might not be able to use that approach to make a decision.
Yes, erosion is another factor. Another thing that I didn't mention is erosion right now is a diagnosis of exclusion.
Yeah. Yeah.
So you really cannot make a diagnosis of plaque erosion in non-culprit region.
Yeah, I understand it.
Yes.
Thank you. Comments, other questions?
Yeah, hi, IK. This is Greg Stone. How are you?
Oh, hi, Greg. I knew you'll be there.
I really enjoyed your talk, and you've made just a fantastic contribution to our understanding of acute coronary syndromes and the utility of OCT over the years. So I just want to acknowledge how important you've been. So I don't want to ask you a question about vulnerable plaque. I actually want to talk about the erosion study and how we might treat STEMIs or ACS differently. I think it was a fascinating study. As I recall, though, altogether, it was about 10% of the patients that ultimately were treated, because not only did you first have to identify an erosion, but I think a very important issue was that you excluded the more severe lesions, those with a diameter stenosis greater than 70%. Exactly. So I guess I was going to ask you kind of a panoply of questions. One, how did you define diameter stenosis 70%? Was that angiographic or was that OCT?
Angiography.
Angiography. Two, we've got an issue that aspiration thrombectomy is class 3 in the guidelines now because it can cause stroke. So how do we diagnose erosion if we shouldn't be routinely performing aspiration thrombectomy? And three, the fact that you had good resolution with deferral. How much of it do you think was the fact that you specifically deferred erosion lesions as opposed to ruptured TICFAs, but with good flow, less than 70% residual stenosis, where that thrombus may also have cleaned up as well over time?
Okay, thank you. So for aspiration thrombectomy, what I am targeting is not really STEMI. I'm targeting non-STEMI. So STEMI, they have to come to the cath lab. And in rare occasions, even without aspiration thrombectomy, you have hard time to find the culprit lesion. And we have a little different data. I know it's not recommended, actually, discouraged. If you do careful, aggressive thrombectomy, you get different results. So I'm not proposing aspiration thrombectomy in every single patient. Maybe large thrombus burden with obviously very careful approach. So target should be non-STEMI, not STEMI. That's why I try to emphasize, non-STEMI you can relatively easily stabilize. And those are the patients that we can measure cross-sectional area using non-invasive techniques such as CT, and then treat them conservatively. And so your third question was?
Are you confident with CT we can differentiate erosion from ruptured plaque, and is that important as long as you've got good flow?
Yes, that's the project that we are doing. I think so, because plaque rupture, at least locally, there will be disrupted flow locally, at least, activate platelets and coagulation system. So you never know, but on the basis of what we have learned, plaque rupture may not be an ideal target.
Okay. And one last question, a different question. I'm always intrigued but troubled by calcific nodules. The one thing I will say in Prospect 1 and Prospect 2, we've now have 1,500 patients with prospective follow-up of all different lesion types for 4 years. And in both Prospect 1 and Prospect 2, we were unable to identify calcific nodules as a risk for a future acute coronary syndromes. And as you know, usually they're not occlusive, and they're very stable types lesions. So are you convinced, in even Renew's work, calcific nodules were only about 5% of the causes of ACS. And I wonder if they're more of a bystander as opposed to really etiologically involved, because we've not been able to validate that.
Yeah, so we look at only the culprit lesion. And as I proposed in our new algorithm, and you exclude plaque rupture without superficial lipid with fibrous cap disruption, and you exclude erosion, and then you have calcified plaque. And then those three subtypes are very different. You cannot mix them up. So if you rule out the other two, only thing left is calcified nodule.
Yeah, we probably would have called your first and third subtypes as calcified nodules. I'll have to check with the Kiko.
No, so the calcified nodule and nodular calcification, that's very confusing terminology. So Reno described both. Nodular calcification is a benign type, which you see quite often. And in the IVUS study, with IVUS, you really cannot distinguish those three subtypes. And it looks like they pulled nodular calcification with eruptive nodules together, which is understandable with low resolution of IVUS.
No, I think you're right. And it may be with OCT that you can differentiate the two types.
Yeah.
I totally agree. Thank you.
Thank you very much. Any other comment or question?
Filippo here. Can I ask a question?
Oh, hi, Filippo.
Hi. Valentin, can I ask a question?
Sure. It's nice to see you, by the way, Filippo.
Well, okay, you are the father of OCT, and I've been fascinated by your narration. I'd like to go back to plaque healing, because I think it's really a fascinating notion, because it's a sort of protective mechanism. In a study, we found that plaque healing is very, very rare in patients with repeated acute episodes, while the prevalence of plaque healing is very high in patients with a long history of stable angina without acute events. So it looks like that it is a protective mechanism, and explain perhaps why so many vulnerable plaques eventually do not lead to an acute event simply because they heal. Now, in your vast experience with plaque healing, do you think that this might become a new therapeutic target?
I think so. Yes. Yeah, we are doing currently doing a study to better understand the relationship. So once we have the data, I can come up with better explanation, better plan. But I think depending on the type, the therapy should be altered.
Okay, thank you. I'd like to introduce Dr. Filippo Crea to all of you, by the way. You are in Italy, of course, Filippo.
Yes, in my office.
He's the new editor of the European Journal of Cardiology, and congratulations. We already talked before, but I'd like to introduce you to everybody, since although we are very involved with Jack, we read your journal every week.
Thank you, Valentin, for your kind words.
Okay, well, look, this was a fantastic session, and it's nice to see you, IK, to Greg Stone, who is contributing significantly from another angle, and to see Filippo Crea. He has of the best summaries of the atherosclerotic process very recently written by him. So it is a pleasure to be here with all of you, and this is one of the best sessions we had thus far. Thank you very much to everybody. Thank you, IK.
Thank you, Dr. Fuster. Bye-bye.
Bye-bye.
You're okay.
Bye.